This is basically the case scenario. So we'll just go through a different vignette. There are seven, I think seven vignettes are there. Each vignette has some questions. So you have to just read the vignette and you need to answer the questions. So this is the first vignette. So the 46-year-old gentleman, and of course, the total overall time period is 30 minutes. So 20 minutes will be for the case and 10 minutes for the CBS station. So this is a maximum 5 minutes extension to be given. Okay, so this is how we need to finish it up. So any questions which you don't know, you just tell me to pass so that we will not waste time on that. So this is a case of 46-year-old gentleman. He has a history of road traffic accident. When he came to the hospital, he's drowsy but restless. He's like following the commands, but he's very drowsy actually. So he's quite tachycardic and there are cold peripheries. He's hypotensive, and if on examination by the ER doctor, they have found out that there are extensive trauma to the right lower limb with lot of swelling and contusions, and there are also contusions and swelling over the abdominal wall, both on the left side and right side. And also there is a, you can say the right lower limb is massively swollen and the patient GCS is 11/15. So the ER doctor has given him around 1500 ml of fluid. So after the fluid, he shows a partial recovery. The blood pressure has transiently improved to 88/45. And the questions for you, like this patient with a trauma. So what are the guiding principles in the initial management of this kind of patients? Like any guidelines do you routinely follow, and can you suggest that how do you proceed with his management?
Yes. Our principle, this is RTA polytrauma with long bone fluxing hemorrhagic shock and hemorrhagic hypovolemic shock with long bone, long extremities, major bleeding, and mostly also intra-abdominal. So I will start by ABCDE approach. Patient, I will maintain his oxygenation, maintain his airway, removing any foreign body, any and I feel the patient, if I feel the patient not can't protect the airway, we'll go to intubation. Patient, I think is drowsy and his Glasgow scale dropping. Breathing also, I will check both equal air entry both side to exclude any life-threatening pneumothorax or hemothorax. Circulation, I would do two large cannulas with single cross matching and already started IV fluid resuscitation. I will send the cross matching, prepare for massive blood transfusion protocol for unit blood, for unit plasma, for cryo, for platelet to be ready. And
So you are following this switch guidelines. This is basically this is
guidelines.
which as per the which guidelines you are telling.
Atlas protocol, according to Atlas protocol, advanced trauma life support. And
ATLS, ATLS,
ATLS, yes.
ATLS. Okay. So there are how many surveys are there in the ATLS?
How many what, sir?
How many survey you normally do in ATLS?
Survey. Yeah, now.
Yeah, trauma survey. Yeah. So do you know what is called primary survey, secondary survey, tertiary
Yes,
survey?
sir. Yes, sir. We have primary survey and second survey, tertiary survey. I
So
am
what do you
going
do
now.
in,
First
yeah.
is a primary survey, low
Mm,
ABCD approach.
mm,
After stabilizing the patient, we will go to from head to toe secondary survey with started to do the clearance of the spine injury by CT and band CT for brain and spine and chest and abdomen. This secondary survey after stabilizing the patient. And ask about the history of the ample history of allergy and medication and everything. Uh, this is in the at the end of the secondary survey.
okay. So in this patient, what are the differential diagnosis of hemodynamic instability and shock?
Patient
What are the
need.
different causes of shock?
Yes, we have for this trauma patient, we'll start by
Yeah.
hemorrhagic and hypovolemic shock, followed by obstructive shock. We'll search for any tension pneumothorax or cardiac tamponade, any tamponading for chest and lung, for heart and lung. Also, the hemorrhagic regarding vascular injury, major aortic injury. Uh, uh, this is the mainly. في neurogenic shock and vasopagic shock. Later in the patient, if suspected infection, will go to the sepsis later on. But mainly hemorrhagic and hypovolemic and
Okay.
obstruct.
Do you know what is called trimodal distribution of death in trauma?
Trimodal distribution of this.
Do you know this? What is called golden hour and
Uh,
what is called trimodal distribution of death?
uh, Trimodal, the three causes of death in the mainly of the admission by the life-threatening condition that, as in this case, from hemorrhagic shock and bleeding and maybe that obstructive causes.
So why it is called trimodal distribution of death?
Uh,
Why it is called trimodal?
because it is timing factor. يعني life threatening, it will
So
happen within minutes.
how many peaks are there?
Three
So
peaks within
so first
minutes.
peak usually within the death happens within how many hours? Second peak is the death happens within how many hours? And what is the reason? Third peak.
First peak within minutes can happen. يعني less than 1 hour can happen. Second peak, this is because of the life threatening condition. After that, from 1 hour to 24 hours, delayed complication from recurrence of bleeding or uh, uh, and there is third one. This is from a long-term hospital admission from sepsis and infection and hospital-acquired mortalities like DVT and
Okay. Now this patient comes to complaints of severe left shoulder pain and thorax. He remains tachypnic, low saturation, normal breath sounds. There is very few audible heart sounds. He is quite tachypnic and blood pressure is low. And you have taken an ABG and this is the ABG report. Even after you given 1.5 liter of fluid, there is no response and there is engorged and distended neck veins. So the ABG is showing severe metabolic acidosis, okay, with lactate of 8.5 and I'll give you the echo has been done on the bedside and this is the echo picture. So what is your diagnosis from this ABG echo and the history?
yes. By the history, this is a big triad by muffled sound and engorged vein and shock and tachycardia. and this echo showed moderate amount of pericardial effusion, mostly hemopericardium with right atrium collapsed. So it mostly cardiac tamponade and need urgent pericardiocentesis and may cardiovascular surgeon to be beside.
So you also see this ECG. The ECG has been taken that time, and we'll go to the question. So, like, now how do you proceed with this? The patient had a pericardial tamponade, and how do you proceed?
Yes, my plan now, I resuscitate the patient at bed for EBCDA, giving the fluid and urgent pericardiocentesis cardiac by echo, and call for cardiovascular surgeon. Maybe patient may need open window to release the heart. And same time, following the massive blood transfusion protocol, 1 to 1 to 1 blood and backed RBCs, plasma and cryo and platelet. Uh, um,
So the main treatment of pericardial tamponade is what?
urgent pericardiocentesis and
So how do you do pericardiocentesis in this patient?
the techniques here,
Yeah.
technique guided by in the apical window, guided by echo with
Which window is better?
subcostal
In
window,
okay.
subcostal window under a
Okay.
complete aseptic technique and going by the
What is the
bacterial
name of the technique?
uh, I don't know, pericardiocentesis, but
What is
technique
the name of
itself
the technique? No,
uh,
pericardiocentesis is the procedure, but
is
which technique you do pericardiocentesis? What is the name of the technique?
uh, is,
Okay.
not a name, it's not there.
Now tell me the ECG finding. You have noted this. What is the typical ECG finding is
Uh,
called?
yes, this is electrical alternate.
Okay,
Uh,
fine. So now I'm showing you the ultrasound and the ultrasound of liver, the spleen and the lung ultrasound. So just comment on the ultrasound, abdominal ultrasound and the lung ultrasound.
Regarding ultrasound, the hepatorenal window, there is contusion in the liver and there is hepatorenal moderate amount of fluid. Also, spleen, there is hyperdense areas. Looks also there is contusion there. Regarding lung window, uh,
So this is
uh,
called this contusion is called in a trauma patient. This contusion in the spleen is called,
lacerations.
yeah.
Yes.
And what does the lung ultrasound shows?
Lung ultrasound, there is multiple B lines there,
Okay.
and there
And
is
what is
also
this image? Last image shows.
the
Uh,
last image. There is hyperdense flora. Looks also there is some contusions
okay.
the lung
Okay.
also.
Okay. So now suppose this patient is hemodynamic unstable and this is the ultrasound finding. So what do you do further? You have already given a blood products and fluids. Still the patient is persistently hemodynamically unstable and you already
Yes.
do a bedside echo, the ultrasound, and this is the ultrasound finding what you have seen. So how do you proceed further?
If patient still despite following the full massive blood transfusion protocol, tranexamic 1 gram, bolus 1 gram, 8 hours, and blood products following.
No, you have already given all the blood products. Still patient
Yes.
blood pressure is on the lower side.
Okay, I will call the urgently the surgeon to see if patient need urgent laparotomy to
Okay.
post
So
the damage
yeah, so you
control.
have done a exploratory laparotomy. The patient was shifted to the OT, and after the exploratory laparotomy, the splenectomy has been done because of the extensive laceration. The liver injury was managed conservatively. Then he was shifted to the ICU. Almost he has received 13 units of blood, lot of FFP and RDP. And
Mm.
basically, I just want to ask you, what is the scenario like? These patients of trauma, when they receive so many blood and blood product, this is something called which
Massive,
type of
massive,
massive
yes, this
transfusion
is a massive
protocol?
blood transfusion
Right.
protocol. Yes.
Yeah. So you send the SB and the other parameters next day. So this is the SB. Basically, the INR is deranged, the APTT is deranged, platelets are low, the TLC
Mm.
is high, and so like any further workup you need to do in your hospital?
Yes. By this, sir, patients still not reaching the targets of the massive blood transfusion protocol. I think
Yeah.
patient need to we need to send fibrinogen, the dimer, put sample for TIG or
Yeah.
rectal
So you told that you will send take. What is take actually? Can you just describe the take?
thrombelastography. This is a fast test within 10 minutes can tell us
So,
which.
just describe the different take that picture here is shown here. So one, two, three, four. What does this four take pictures tells you? So one is like
Was one this is hyperfibrinolysis. Sorry,
which one?
hypercoagulability. Hypercoagulability. This is
Okay,
hypercoagulability.
fine.
Yes.
Okay, two, number two.
Two, this is prolonged K time and R time. I think this is anticoagulant or factor deficiency hemophilia.
And number three.
Number three, I think this is looks normal for me.
Do you find that this MA is normal?
No, 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 no. This is decreased in May. Sorry, this is
Yeah,
decreased in May. So,
right.
platelet, I think, freezes.
Okay, and this last one.
This is hyperfibrinolysis.
Okay,
Yes.
fine. So now this overnight the patient remain hypotensive and still the patient is throwing hemorrhagic drains. And in the over the throughout the night the patient urine output was lower side and the abdominal girth it started increasing and there is a rising in the peak pressure and plateau pressure and NORAD support also increased. Basically, don't go to into the investigations, but I'll just show you the picture. Like here is the abdomen is quite tensed, the X-ray
Mm.
is okay, and you see the on ventilator there is a high peak and plateau pressure. Okay. So what is your like cause of the decreased urine output in your patient? What is your diagnosis for him?
By this abdomen and increased resistance on the ventilator and still drain is coming out. I think patient go into abdominal compartmental syndrome and need to measure
Okay.
the intravesical pressure. طبعا with oligoric started acute kidney injury, so it's typical for acute compartmental abdomen compartmental, and patient need to how to proceed. في non-surgical surgical we decompress from up and down by NGT and rectal enema and paracentesis, decrease the peritoneal fluid. At the end, if still we can better to do some relaxant for the patient to release to decrease the tension of the muscle. At the end, if it's still not improving and time is out, we will call for decompressive laboratory for the patient.
Okay. So any means to diagnose your abdominal compartment syndrome?
This by intravesical measuring of the intra-abdominal pressure. It will be more than 12 with started organ failure, like acute kidney injury here.
And which by which method you measure the abdominal compartment syndrome? How to
Uh,
measure the abdominal compartment syndrome? Like,
by intravesical
okay,
catheter.
okay, okay, fine. So now this patient was on mechanical ventilator. So because of the decreased urine output, your nephrologist planned to do a dialysis, and you told your junior to put a SD catheter. So SD catheter was inserted, and after the insertion of the SD catheter, the patient getting desaturated, and there is again uh, pressures like the peak pressure and plateau pressure has gone up, and this is the X-ray post procedure. So, can you describe the
Now,
X-ray?
after
Oh.
yes, after this invasive procedure, the patient there is this is the X-ray showing chest X-ray showing right pneumothorax with the little shifting the mediastinum, and I think this is causing tension pneumothorax. The ETT is there. The left lung there is hyper congestion. Yes.
Okay. So, how do you like manage this condition?
Uh, this is by firstly طبعا this clinical diagnosis. We're not waiting for any more confirmable, but the needle decompression in the mid-clavicular second space, large box 16, then followed by intercostal ICD in the fourth or fifth anterior axillary space. ICD under water seal.
So, how do you critically debrief this incidents to your quality team and to your junior?
Yes, such events we can, as per Spike's protocol, طبعا we should make a family meeting.
Which protocol you told?
Spike's protocol. I will
What is the full form of spike?
Spike, I will make a family meeting, sitting in a comfortable place with checking the perception of the family, what they know about the scenario of the case. Then I will ask them if they invite anyone to become more comfortable and to see, to listen to the what's happening to the patient. Then I will acknowledge that there is some complication happen post one procedure in ICU, and this is can happen, and we manage it as per protocol on time. And patient, I will explain what's happened as a complication, then what we have done and how we manage it, and I will reassure them that I will hear for their what they think about that, and I will reassure them about we are following the protocols and the guidelines, and we'll do incidental reporting about what happened to make an action plan to decrease that event in ICU.
Okay. So, can we start the CBS?
Okay, sir.
Are you able to see the screen?
Yes, sir, I am seeing.
Yeah. So we'll go so one by one. Like the first domain, like this is say the X-ray. So, are you able to see the X-ray?
Yes.
Sorry, this CT 45-year-old male present with
So, sir,
sudden
the
collapse.
screen, not, sir, the screen, I am seeing you only, no the,
Acha, you are not able to see
yes, yes,
now. Okay.
yes, sir, it's clear now.
Okay. Fine. So tell me the CT finding.
Yes, something like this. We have here CT brain showing subarachnoid hemorrhage in the sylvian fissures, and this is subarachnoid hemorrhage here. So with brain loss of gray and white matter differentiation, so there is brain edema there, obstruction the most of the ventricles.
What is your
Uh,
immediate priority in the management?
Immediate priority as per protocol, airway breathing circulation. We maintain patient airway and maintaining induced blood pressure, euvolemic, euthermic, decreasing the intracranial pressure by elevating the head 30 degree, and giving hyperosmolar therapy.
Yeah.
And
What investigation
we
you will do further?
yes, we will do CT angio
Hmm.
to rule out aneurysmal for neurosurgical consultation, to if you need to secure the aneurysm by coiling or clipping, and doing ICP monitoring also for the patient. Uh, uh, later on, we can do also transcranial Doppler and EEG for the patient. For
Identify the.
other investigation, sir, sorry, we'll send routine
Oh,
CBC
it's
for
okay.
platelet
It's
correction.
okay.
I know. Yes.
It's okay. Now just identify the graphs A, B, and
Uh,
C. Identify the instrument on the left side and the graph on the right side.
this is intraventricular IVD for ICB monitoring. Uh, First one, I think this is normal peaks for the ICB. Second one, B2, the tidal wave more than B1. So it is a decreased of brain compliance, increased ICB mostly. Uh,
Can you tell me the Brain Trauma Foundation guidelines for ICP measurement?
Brain foundation for ICB measurement. Uh, so this is indication or
Indication of ICP measurement.
indication ICB. We have with normal CT or with finding in CT. If CT normal, but patient with glaucoma scale decreasing less than decreasing or repeated vomiting or his age is less than 10 years or more than 60 years, you will need. If CT finding with intracranial bleeding or subacranial hemorrhage with increasing the sign of brain edema, you will need also ICB monitoring.
Do you know what is Lundberg waves?
Lumbar waves. Yes, this is في two types A and B. Uh, uh, I say if more than increases ICB for 5 to 10 minutes for
Yeah, what are the different Lundberg A, B, and C? Which is more dangerous?
the more dangerous B.
B, are you sure?
Sorry, sir. No, not B. Sorry. Uh, A
Okay.
is
Okay. So this is identify the ultrasound.
this is ultrasound for globe optic showing the optic nerve sheath diameter. It should be less than 6 mm.
Okay.
This now, sir,
So,
for the
okay, what are the different non-invasive ICP monitoring devices?
uh, transcranial Doppler. This optic nerve sheath diameter by ultrasound. Ophthalmoscope also we can use for edema by through ophthalmoscope. Uh, um,
Just read this case. Just read this case, then we'll have the questions.
yes, yeah. Okay, sir.
This is the CSF analysis.
Yes.
Go through the CSF analysis.
This excessive showing increasing protein, decreasing in glucose, cells showing lymphocytosis. Uh, so patient is going with meningitis, viral or TB or but we're waiting for culture, and I will start for patient. طبعا patient is immunocompromised, and I should start antibiotic as early as possible as a for hospital immunocompromised. I will start my Improvinam and Vanco and antiviral also.
So what
I
is
think
the differential diagnosis of TB meningitis?
differential of TB meningitis.
Yeah.
TB meningitis يعني as lymphocytosis, it will be TB or viral or aseptic meningitis, autoimmune colitis.
Can it be like cryptococcal meningitis?
Uh, Cryptococcal meningitis, it is common for immunocompromised patient like this patient, yes.
How do you differentiate between TB and cryptococcal meningitis?
Uh, I will send the PCR for CSF and
What
compute
specific test you will do?
specific test, cryptococcal antigen, and for TB, I will do quantiferon PCR.
Okay. Identify the MRI.
MRI showing C1, 2, 3, 4, 5. There is C5-6 dislocation.
How do you intubate this patient?
By inline manual stabilization for the neck with rapid sequence intubation to person to maintain the airway to maintain the spine in place using a better video laryngoscope and with the best person who can do the intubation.
What does this figure shows?
I think this is intravesical intra-abdominal pressure measuring equipment.
Okay. What level will transduce the equipments?
They have a thromblastic level in the level of the thromblastic level.
These two equipments, A and B. Identify.
Yes. B, this is IABB, intra-aortic balloon
No,
pump
no, no.
monitor.
It's not IBP. Okay. Identify this.
This is for brain tissue oxygenation monitor.
Okay. Yeah, fine.
Yes.
Okay. Thank you. Yes. Thanks.